Who's unmuted? Good morning, everybody. My name is Kelly Sandaker. I'm the SURSAC administrator today, and I'm glad to be here. And I'm going to go ahead and start off with our disclaimers. This meeting is being recorded and live streamed on TVW. This meeting recording will be shared on the HCA website and on a page dedicated to SURSAC meeting information. The meeting recording is open to public disclosure. Please do not disclose any private or confidential information. Next slide, please. Guidelines for public feedback. There will be 10 minutes at the beginning of the meeting reserved for public comment and 5 minutes at the end. If you are not a committee member and would like to make a comment during a particular discussion, please raise your hand for facilitator awareness. If time allows, public comment on that topic will be invited before moving on to the next item. Feedback that is not provided during the meeting can be submitted via email at any time to HCA esb5476@hca.wa.gov. I'll go ahead and today we have Tony Walton as our interim chair, and I'm going to go ahead and start off with attendance this morning. Jason McGill, Michelle Martinez,
Present.
Blake Ellison,
Present.
Tim Candello.
Present. Good morning.
Good morning, Tim. Sarah Melfi-Klein.
Present.
Brianna Peterson.
Present.
Tony Walton.
Oh, present.
Rachel Downs.
Present.
Haley Fuller. Alex Sheehan.
Present.
Amber Leaders. Senator Manika Dhingra. Senator John Braun. Representative Lauren Davis.
Morning.
Morning. Representative Dan Griffey. Caleb Mantigreen.
Good morning. Present.
Morning. Don Julian Saucer.
Good morning.
Morning. Sean Meyer. Alexa Orr.
It's Alexi, and I'm here.
Amber Cope.
I'm here.
Randy Flood. Stormy Howe. Chad Enright.
Present.
Don Hayden.
Good morning.
Morning. Nikki Lewis. Sherry Candelero.
Present and good morning.
Morning. Hey, James, I know you already wrote in the chat, but I'm going to say your name anyway. You don't have to state verbally. I'm just going to be saying it, but I will count you here. James Tillett as present. Christine Lynch.
Present.
Sarah Gillard. Donald Tanksley.
Here and good morning.
Malika Lamont.
Present.
Addie Adwell.
Present. Good morning.
Good morning. Kevin Ballard.
Present.
Hunter McKim. Representative Jamala Taylor. Representative Gina Mossbrocker.
It's Jamila, present.
Jamila Taylor. Excuse me. Sorry, Representative Jamila Taylor. Sorry. And then we didn't hear nothing from All right, that is full attendance. I will go ahead and pass off for Tony for any kind of HCA announcements.
Yeah, thanks so much, Kelly. Good morning, everybody. Welcome to the September SURSAC meeting. It's great to see so many people present here from both the committee and from interested community members. Once again, I'm chairing the meeting today and just feel honored and grateful to do so. Back in July, I promised to provide updates regarding Recovery Navigator program data, indicated that we would develop an internal work group at the Healthcare Authority, which we have, and we've been meeting bi-weekly since then to work on some of the issues and recommendations that the committee has developed and put forth regarding the collection of data around the Recovery Navigator program. So I just have a couple of small updates to provide regarding that. First, just to confirm that a internal working group was developed, including multiple divisions within the Healthcare Authority, including our Clinical Quality Care Transformation Team, Medicaid Programs Division, as well as obviously DBHR. We have recently brought Recovery Navigator program data and the pending dashboard, I know everyone's been waiting for that for a while, to the Data Utilization Committee. And so just for a little bit of background within the Healthcare Authority, obviously when we're talking about personal health information, confidentiality, and the various categories of data which could be presented, there's a lot of attention to that to ensure that we are following HIPAA regulations, CFR 42 Part 2. And so we do have a data utilization committee that's developed of internal HCA staff. And we did present the dashboard to that committee and got approval to move forward with the next step, both so that we can create an external facing version of the dashboard for SURSAC and interested community members, as well as to help support the pending, not evaluation, but descriptive analysis that WISIP is doing, the Washington State Institute for Public Policy. And so that's a big step that, we had to kind of reach in order to move on to the next, really getting this dashboard published for external facing. And so I just wanted to share that update. We're also reviewing and revising the error tool. It's basically coding embedded within a software that allows us to, when a workbook is submitted, and just a reminder that for right now, Recovery Navigator program data are all submitted through an Excel workbook. We're able to put that workbook through this error tool to identify any missing elements or identify any areas where if we set specific categories, if those categories were subverted in any way, and then we can provide additional feedback to the submit. And then we're also exploring options for gathering demographic information around both the outreach and referral stage, as well as with case management. And just, I think just a reminder, we kind of bucket those two populations for Recovery Navigator program into those kind of two different situations in which somebody might be engaged with Recovery Navigator program staff. And one is referral and outreach, and the other is case management. And so really trying to ensure that we can improve one of those, both of them simultaneously, but kind of focusing our efforts on ensuring that for when somebody's enrolled in the Recovery Navigator program, that their case management data are complete and inclusive of some of those demographic data that we've heard concerns from the committee and others about some of those missing variables. So that's a quick update on the Recovery Navigator program data work. And then real quick, wanted to also share, you might have seen the Gov delivery announcement, but we recently selected 3 additional proposed sites for the Health Engagement Hub pilot project. This was the work of a number of hours and individuals working within the Healthcare Authority and with Department of Health to basically identify and review proposals that we received from a number of community-based organizations and tribes. We're in the process of contracting for the 3 new sites, and those contracts are not executed. So that's just, putting that footnote on there. But we are intended and hopeful to be able to work with Sound Pathways up in Snohomish County area, as well as the Lummi tribe and the Yakima Nation tribe. And so really excited to be able to work with more tribal partners in this area, as well as with Sound Pathways, which is a syringe service program. And so more to come on that. We can always have additional updates if the SURSAC is interested in hearing more about the Health Engagement Hub, both our initial sites, Blue Mountain, Heart to Heart, and Health Point, as well as the pending 3 additional sites. And also just a huge shout out to all of our partners that we're working with around evaluation and setting up a data collection framework for the Health Engagement Hub program to ensure that we're doing this in a way that we can evaluate some of those outcomes long term. Oh, thank you. What's the question? Oh, Tony, is there any intersection or alignment between, I'll just read it for everyone in case anyone can't see the chat. Is there any intersection or alignment, and this is from Caleb, between RNP client data, Health Engagement Hub client data, SUD treatment agency data elements, and syringe service program services data tracking? That's a very interesting question. You mean like the ability to basically pull from those various data sources? And it's just kind of like a follow-up to the SUD prevalence data we were talking about last month? Or Kayla, maybe you can.
Well, sort of at minimum other common data elements so we can understand how people are accessing different services from an equity perspective, how representative they are of the populations we're trying to serve. And then, the holy grail is the ability to actually have clients just have data in one system and the systems come to them rather than them having to go to all the systems and all the data.
Oh, gotcha. Okay, and so with all those data we're collecting with Recovery Navigator program, and then now adding on the 5 Health Engagement Hub sites, like how can we ensure that we're aligning those efforts and having minimal data burden on the participants of those kind of similar aligned programs?
Correct. That's my question.
Yeah, I haven't really thought about the intersection of Health Engagement Hub client data with Recovery Navigator program client data. I mean, I think the SUD treatment agency data elements, at least for Medicaid, we're able to kind of integrate those or bring those in through partnerships with research and data analysis at Department of Social Health and Services. The SSP services data tracking, I think, obviously with Blue Mountain Heart to Heart and Sound Pathways, I think that there's a little bit, we'd be able to track those data a little bit easier since they're both syringe service programs. But in terms of tracking SSP service access for a Recovery Navigator program, I don't believe that's something that's currently collected, but we can definitely take that back and try to understand like the extent of, how SSPs are supporting RNP clients.
Okay, just the idea, of course, if all these things are sort of happening in parallel with each other, is there going to be any alignment? That's it.
Yeah, no, thank you. That's really helpful.
And there are comments in here in the chat, as you can see, of course, around confidentiality issues. And I'm not pretending these are easy things to do or they should all be thrown into one pool that everybody can look at. Of course not. But just wondering if, as people are discussing these different data systems, if there are any conversations about trying to have some coordinated efforts and at minimum common data elements, even if there won't be any time soon, if ever, where there's sort of one client database across all the systems.
Yeah, Yumiko, who presented at the last meeting, I know is really working closely with our clinical quality care transformation team and leadership around that. But we'll definitely kind of get this feedback to that team, and maybe an opportunity for a future agenda item for SURSAC too, just to kind of have a little more dedicated time to talk about this, because I have a feeling based on some of the comments in the chat that it may allow for a pretty good conversation. Because I'm certain even, with all the work that Yumiko has done, there might be some considerations in that area that we haven't kind of pursued.
I don't see any further questions at this moment. Thank you, Tony.
Yeah, just really good comments. So I would just, if anyone's tracking the conversation, just check out chat because I think there's good context around kind of some of the barriers and why, but yeah, and why this is complicated.
I'm going to go ahead and pass it off to Blake Ellison at this point.
All right. Thank you, Kelly. Good morning, folks. Now it's time for public comment. So if any member of the public would like to make comments, please go ahead and raise your hand virtually and we will get to you. You have about 3 minutes to make that comment. So any comments from the public? Seeing any hands at the moment. Again, time for public comment. If you would like to make one, please raise your hand virtually. All right, last call for public comment. All right. Thanks, folks. We'll move on to walk-on item requests. Is there any item that we would like to add on to the meeting if we have time? Any items that we want to add on for discussion today? Go ahead and again raise your hand if you have an item. Right. See no hands, so we'll go ahead and move on to Cody with Minty.
I didn't put myself on the agenda. I just wanted to give some background before you share.
Yes,
this
of course.
is fine that you shared it. Yeah, just let me go ahead and give some background. Good morning, everybody. Kelly back here again. So just real quick. So as you guys know, today, this month is Recovery Month in September. And so SURSAC, the committee, the HCA SURSAC people here got together and said, what can we do for the month of September? And so we are doing the SURS plan progress report, and that's pretty time consuming and heavy to go through. And so we wanted to make sure that we did something to honor Recovery Month. And so we came up with a Menchie, and it's pretty cool. Minty? Oh, Minty. Menchie. I think Menchie's where you eat. But but yeah, and so and I'm just so happy we get to do something that can really, just something creative that can come up. So at the beginning of the meeting, we'll do this where he'll give you the code. He's going to go into his little explanation of what this is, and you put in a couple words, and then at the end, we're going to see what it looks like at the end, and we'll have a word cloud of a couple words of what recovery means to you. And so I'm just appreciative of everybody on the call today. Thank you so much. Go ahead, Cody.
Awesome. Thank you. All right. So instructions on how to do the Menti in order to interact with this activity. Open up your browser from any item, phone, computer, etc. Go to menti.com and type in the 8-digit code up top, which is 9334118. And then it should take you to the prompt itself. So I will type the code onto the chat, and then I will jump to the next screen. What does recovery mean to you in 1 or 2 words? So once you join the page, you could type in your responses, and they will show up in a word cloud here.
Worked out. Yeah.
And then, like Kelly said at the end, we will see the responses in form of a word cloud. Awesome. I see freedom, life, hope. All right, and Kelly is I'll keep this screen up until you need me to stop showing my screen, and we will share the results.
All right, Cody, you can go ahead and stop sharing your screen. We're gonna move on to the next person most likely for presentation. Yeah, and we're gonna come back to that though. It's looking cool already. Also in the chat, I've put in National Recovery Month for everybody, so that if you want a toolkit from SRAMSA, you can go ahead and take a look at it. And there's some cool stuff for your organizations or individual self if you want to know more about National Recovery Month. Oh, thank you, Lisa, for putting that in the chat. Go ahead, Blake.
All right, so thank you, Cody. We are moving on to SURS Plan Progress Report with Brianna. Brianna, you there?
1 second.
All right. Thank you.
Okay, so hope everybody can hear me.
We got you. We can hear you.
A little bit of feedback. We good? Okay. Hi and welcome. My name is Brianna Peterson. I am my title is 5476 Technical Plan Developer and Report Administrator. But I've been writing a lot of reports since then. So, but here we'll talk about the SURS Plan Progress Report. I wanted to give a little bit of an update on how we went about this process this year. For one, we heard all the feedback last year about not having enough time to review it. So we did send this out. Kelly did send this out on August 29th. So we'll be going over it today, and you'll have an additional week to provide any comments or feedback. This year as well, we went with this presentation instead of just having the report on the screen and scrolling through it. We will do that to talk about certain sections if you guys want to, but providing this presentation to just go over the entire report, the changes that were made, and areas where we're looking for any additional feedback or comments on to focus on for this meeting. Next slide. So here I have the report comparison from last year to this year. Last year there was a short SURSAC overview. This time we decided to open it up more to talk about all the presentations and all the progress and feedback that we discussed during the, I guess, the year to date. Regarding the implementation updates and R&P, we also, last year, we focused on the crosswalk from the legislative appropriations. We're not including that in this one. We're just focusing on the implementation updates that we received from 5536. There's also not the section about the change in state law. Again, we're focusing more on the implementation updates that we received from the recommendations that were put forth. Instead of listing them by number, we group them back into the categories that they originated from: the treatment, the data, the outreach, and the recovery support services. Last year there was a breakdown of the synopsis of the recommendation, the legislative response, and the HC's update. Again, we are just focusing on the update to the implementation of the recommendations. I did make sure to link it back to the recommendation just in case for, historical reference, but we're just really focusing on the implementation updates and hope to continue that for the coming years, that we'll continue this report. And then the program updates from 5476 kind of stay the same. They're still at the bottom, and they still will have updates from the last fiscal year. You can go to the next slide. Oh, one back. So part of the SURSAC section, again, I put in the direction that we went for 2024, listing out the presentations based on the programs from 5476 and 5536, along with additional presentations from the 1115 waiver, Scala Northwest, Icelandic model, DCYF, the 1619, and more. I also provided a small synopsis of the feedback that we received from the RNP quarterly reports, the feedback that we received from SURSAC, and the presentations that were provided from the BHASOs and their providers. Does anybody have any questions so far? I can't see it, so
No hands raised yet.
nope. Okay, no, we'll keep on going then. The next slide. So this kind of just brief overview of the implementation updates. Under treatment, we'll have updates on the health engagement hubs, the SUDISA work group, the safe supply work group, and the increased access to OTPs. I just wanted to give you a brief update on the SUDISA. We will be providing the report for you guys to review, hopefully the next week or so. That's the plan, as they're wrapping up their work group. And we're still working on obtaining the safe supply from the contractor, is it HMA, regarding that report. If anybody wants to see that, you guys can email the 5476 inbox to let us know. You can go to the next slide. We provided updates on the RNP quarterly report data, the data integration platform, and the substance use disorder comprehensive assessment and reports. There is a couple reports in there that are going to be linked to the reports that are also coming out at the end of this year, and the one that was submitted earlier this in July as well. You can go to the next one. We have provided implementation updates on the diversion, outreach, and engagement on the pretrial diversion program, the LEAD statewide grant program, arrest and jail alternatives grant program, and the opioid awareness campaign for youth. In the recovery support services, we're providing updates on outreach to develop equitable recovery housing and diversity, equity, and inclusion training for recovery housing providers, training of foster and kinship parents of children who use substances, employment and education pathways, the expansion of the Washington Recovery Helpline and asset mapping, the recovery housing grant program, the safe housing for youth exiting inpatient facilities, and grant funding for youth housing to provide behavioral health services, and the short-term housing vouchers. The 5476 program updates, kind of similar to what was last year. We're just updating the programs, providing any data and success stories that we have available to us. Some are a little bit more extensive than others, but we are working all around to beef up those programs to provide as much data as we can regarding the services that they're providing and the individual served. Go to the next slide. So this section is where I'm going to see if you guys have any feedback or comments on. As part of the conclusion, we've incorporated the unrealized recommendations. We did note that there was 2 others that were not in the original report, so I apologize. As we were doing this presentation, we noticed that there was 2 more. So it's the funding for it's like the actualization of the funding for legal representation for parents and families. I know that they did include indigent in certain categories, but it wasn't for the parents and families in kinship and foster care. And we also, the LGBTQIA specific housing was also not fully, there is, the DEI training and there is the housing grant, but it wasn't fully targeted to just LGBTQIA housing. So those we did incorporate here. And we want to acknowledge that although many aspects of the SURS plan have been supported through the state budget and legislation, primarily through 5536 from the 2023 session, there remains some elements of the plan which have not been actualized or fully adopted. These are noted in the report as key pieces of the plan that are intended to work cohesively with the other pieces to strengthen its overall effectiveness, and that the SURSAC still supports these recommendations for consideration during the 2025 session. We're open to any questions or suggestions you have that could strengthen the case for these remaining recommendations, or if they were ancillary efforts which helped address these concerns. So I'll open it up to the group. Yeah, for non-custodial parents mainly, yeah.
Yeah, and also
So do you guys have any
recognizing that.
like suggestions on how we can approach this? Tony?
So the, oh, go ahead. Sorry, I didn't raise my hand. I just started talking.
Amber, go ahead and then we'll get to Tony.
So, just that the RCWs like guarantee children a right to both of their parents, and whenever non-custodial parents are afraid to show up to court or they are not represented in court, anyone that's ever been involved in any sort of a court thing, they know that if you go in there without representation, your chances of advocating for yourself are very low, and also your chances of getting any sort of attention from the court just based on the fact that you don't know how to act in court, or you don't know that you're supposed to make 3 or 4 copies of everything, it makes it so that those other parents aren't engaging in those court proceedings in a way that makes it to where those kids have that actual right to both their parents. Does that make sense?
Yes, it does make sense. And I agree with you, there's, having to do with family matters, it's always difficult, but, adding in those who are affected by substance use, it just makes it even more complicated.
Yeah, Amber, thanks so much for that additional comments. And now Malika's hand. I was just want to say real quick, sorry, Malika, before you talk. Thank you, Brianna, for all the background and for the work put into this. And just, these recommendations were developed 2 years ago, which is amazing because first, time goes by that quickly. But also, I think, the purpose of this, like Brianna stated, is just we wanted to make sure that they weren't lost as we report out on the amazing work that's been happening with the funded elements of the Substance Use Recovery Services Plan. And so please, like Amber did, if there's anything in here that, and that sort of feedback, Amber, that you provided, if you feel like that's not captured in our draft progress report, make sure and add it in there and then send it back to Kelly by what day?
September 16th, I believe, yeah.
By September 16th. We really did try to give everyone a lot more time this year, and just huge shout out to Brianna and Michelle and Sarah and Kelly. They're just really thoughtful about trying to get this before the committee ahead of time, allowing this time for kind of general conversation, and then still having another week to provide any kind of written feedback. And so I think this is a good demonstration of why it's so critical to, that we have this process in place, and we tried to improve it this year. And so just wanted to kind of acknowledge that. And with that, Malika, go ahead.
So for recommendation number 2, well, actually, let me get some clarification first. Do we need to, so if we say it here, do we also need to still send it in writing?
I mean, That would be helpful. I mean, like we have
Okay.
awesome note takers, but I think sometimes, like you're able to demonstrate, really capture something if you put it in writing a little more efficiently.
Okay, thank you. So related to recommendation number 2, I feel like a much more concise way, and I will send this in writing, is to repeal paragraph 2 of section 8 in 5536, which actually made it so that we now have a patchwork of laws across the state related to harm reduction activities, which was supposed to be related to possession and such. So of those tools in order to keep oneself safe. So repeal section 2 of paragraph 8 of 5536. That just seems like a much more clear way to say number 2.
And I think that's still in alignment with the original recommendation. So yeah, that makes sense. Malika, and that's, I mean, you still send it in writing as well, but yeah, I think that's also something that we can capture pretty easily on our end. Thank you. How many recommendations were there total in the SURS plan?
17 from subcommittees and the 18 including the criminal legal recommendation.
Okay, yeah, so just taking a second to acknowledge that it's just been quite a process, and it's been great to kind of see this move forward, and that out of those 17 recommendations, there's some that are still kind of pending out there, and we just didn't want to lose those as we kind of move forward. So appreciate this time and conversation. Maybe pause for any other comments, and then Brianna can.
Is there any other comments regarding the unrealized recommendations? Malika, do you have a new comment, or should I put your hand down?
Sorry, I thought I had put it
We'll
down.
get this together. Yeah,
Okay.
it's all good. Any other questions for Brianna? Okay, Rep. Taylor.
On a recommendation to funding for legal representation of parents and families, including kinship and foster care families, is there a subcommittee or a prioritization on that? Because child protective services cases are different than family law cases, which is parent to parent or parent to third party. Child protective services is involving a parent versus the state, and there are many instances where legal representation is provided, but the question is, at what point does that legal representation get enacted for CPS cases, which then results in dependency. And my hope is that we are able to provide legal representation earlier in the process so that a dependency does not need to be filed where the parent does have legal representation. So there's, like, in family law or court cases involving families, there are 2 different tracks and I'll just summarize that real quickly again. There's a track where it's private parties, parent to parent or parent to third party, and then cases that are involving the state.
Just to clarify, are you recommending that we include that distinction in this section of the report just to be more clear about different options for this, or is there, like, specifically what would you like us to include?
Yeah, I think you're going to need, like, in order to understand where resources need to be prioritized. We are going into a tough budget year, but I think there is a lot of benefit for this community if we clarify what you would like to do in recommendation to around the legal representation and start working towards that. Yes.
Great, thank you so much.
All right, thank you. Amber?
Yeah, thank you for that distinction. I think that in the original recommendation, we were talking about actual civil Gideon for non-custodial parents. In civil family matter cases, Child Protective Services do offer that legal representation, but you have to be involved in services. I think I shared a little bit about my situation when I was younger, about how, because it was Child Protective Services was not involved, it was a situation where the child was actually like not only removed from like my care for 13 years, but removed from my life, and there was just nothing that could have been done about it, because I just didn't have representation to go in there and advocate for me. And I've seen it happen to especially fathers, that don't know their rights, and that don't know, that don't have anyone to go in there and advocate for them and stuff like that. So I agree with Representative Jamila, and I just want to say that before this gets to a point where Child Protective Services is involved, that prevention is what we need, right? So it also costs, I would guess it would cost a lot less to get some sort of legal advocacy in place before it gets to the point where you're in dependency.
Thank you, Amber. Yeah, this is really wonderful feedback, and we'll make sure to follow up if needed for the specific language to include in the report around all this.
Thank you. Any other questions, comments? See no hands. Brianna? Any more from you?
I just want to double check with the group before I go ahead. Is everybody, by a show of hands, can I see if everybody is okay with walking through the entire report, or are you guys okay with submitting feedback at a later point?
We need to show up hands.
Oh, do we want to go through the entire report right now, kind of slowly scrolling, kind of like we did last year? Or do we want to forego and just continue on the meeting?
Go ahead, Malika.
I thought you had prepared a presentation, and that's what we're going through now.
So this is the presentation. I just don't want to sit in silence if we don't have any additional comments or feedback on the report at this time.
Oh, you're done?
The next part is going to be the timeline.
I couldn't hear the timeline. Is that what you said?
The timeline for submitting comments and feedback.
Oh, okay. I feel like there must be more, but I'll leave it up to the group.
So again, just to reiterate, Kelly did submit out this report on August 29th. We are, reviewing the source plan implementation report during this meeting and collecting feedback. And the final comments are due on September 16th for us to submit to legislature, for us to gather and complete and submit to legislature for the next legislative session. And if you have any comments or questions, you can submit them to the HCA ESB 5476 at hca.wa.gov. We can slowly go through the report if the group wants. If that's what the group wants, can you raise your hand?
And while everyone's kind of raising their hand or considering how it's been, 30 minutes, we do have 30 minutes until the Thurston Mason RNP presentation. Just kind of flagging, like, I think the intent was, like, if this is a good use of everyone's time, like, we can definitely kind of go through it, but it's also a really long report. And so, I mean, we do have the time to do it, so I just kind of wanted to flag that. Maybe not thoroughly and every single piece of it. That's why we sent it out ahead of time.
There's a question in the chat. Kayla,
Yeah, question in the chat.
Those figures will be updated for the final version. We're just making sure that, after we received approval from the Data Utilization Committee, that we were okay with those figures.
Go ahead, Caleb. Jolene, I'm assuming you have your hand up to vote for seeing the report. All right, thank you. Go ahead, Caleb.
Yeah, just following up on my question. It sounded like the timeline, sorry, just went past me. It looked like something was going to be done on the 16th, so in a week from today. But I think those data pieces were pretty important, and I know they were raised in the introduction to the report, and we've had a lot of conversations at this meeting about the data pieces. So it seems like a big omission. There's a lot of great stuff in the report, but that seems like a pretty important piece. I'm just, if someone could help me figure out when we would see those, will we have a chance to review and comment on them before the report's submitted, or what is that sequencing and timing going to look like? Thanks.
I can't see like, for whatever reason, like, Caleb, your comments like highlighted, and I guess I'm just getting old. I can't tell which two data pieces we're waiting on.
It's for the RNP.
Okay, thanks. Yeah, no, that's a good point. We are kind of dependent on multiple kind of internal partners to, like, get those data ready to be able to include on the report. And we also have a really kind of strict timeline for these legislative reports because they do have to go through so many approvals within the agency. They go to OFM, but you raise a really good point that, like, seeing that particular kind of data set would be kind of a critical piece of the report. Let's take that back and we can send a follow-up email with kind of if we're going to have like a secondary process specific to those data sets. Maybe we can do that through email, but ensure that the committee has an opportunity to review them. But for right now, just if you can, we'll focus on which content is there, and we'll follow up sometime this week, sooner than later, in the next couple of days. And I think we just need to check with other people that are involved with the approval process.
Okay, thanks.
Yep. So I didn't.
All right, Brian. I saw one hand. Tony. So if you can hear me, Brianna, we saw one hand and raised for seeing the rest of the report.
Yeah, that's what I saw too.
Just one hand.
Okay.
Which makes sense. There's a lot, and when we did this last year, it was, I think we tried to go through it, and it's just really, there's so much there. It's kind of tough to kind of operationalize that within this setting. And so just really hope everyone has enough time this week to kind of look through it, or you've already had a chance to look at it, and we appreciate any feedback through email. And then we'll get a response regarding the RNP data placeholders in the next couple of days. And I'm just checking.
All right.
Yeah, go ahead, Blake.
Looks like Jason is here. Jason, are you available to do your presentation?
I am. And I think the teams from each county is around, hopefully, if we're ready to transition to us.
I think we are. Brianna, did anything left to discuss?
That's it. Thank you for all the feedback. We'll be reviewing it and incorporating what we can into the report.
thank you. Yeah, Jason, if you're ready, that'd be great. And
Sure.
see Nicole is with us as well.
Yeah, I think got the supervisors for each county program. I'm gonna share a really brief PowerPoint to help kind of guide an outline for us as we're going through this. So I'm going to start really briefly just to introduce our two counties programs. Give my slide will respond. That's why it's helpful. So just for a little bit of background, we had existing LEAD programs in each county when 5476 came through and we were awarded the RMP funding to help expand efforts like this. So in 2019, we had partnered with Mason County Public Health in responding to HCA's grant for a LEAD program and got those services originally started back in 2020. And then Thurston County applied as well for a LEAD grant, and we were awarded the RFP to provide those services and contract management, beginning services a year later in 2021. So both those programs were already up and running, and there was significant investment from each county in our region to get that work going, and a lot of investment from stakeholders. When the RMP funding came through, of course, those stakeholders wanted to support the existing work and expand those efforts. I never miss an opportunity to say we're one of the lowest funded regions in terms of RMP services. Actually, we are the lowest funded region. So it was really important to braid additional funding. So essentially with RMP, we were able to double the capacity of the two existing LEAD programs that were serving each county within our region. As it says, with the goal of meeting the RMP goals. So that's a little bit of the background and kind of how we came to fund these two programs to meet the goals. And I'm going to hand it over to the two teams to talk more about what it looks like in each of our communities. So first up, we have Mason County program. Kisa and team, if you're on, you can take it away. Hopefully we're ready.
Great. Thank you, Jason. Hi, I'm Kisa Foley, the Jail Diversion Program Supervisor here in Mason County. I oversee a few different programs with LEAD being one of them. So I'll give kind of an overview of what our LEAD team looks like and what we do. So we're currently comprised with one substance use disorder professional, 6 certified peer counselors, and 1 mental health professional. At this time, all of our current LEAD team members have a history of lived experience themselves, which I think better enables them to connect and build rapport with our participants. We do the clients that we serve in this program and the requirements for the LEAD program, they can experience any or all of these. It's mental health issues, substance use disorder, houselessness, and or frequent contact with law enforcement. And of course, be over 18, we work with adults only. We receive referrals from a variety of different places. We get referrals from law enforcement, and we now have a new mobile outreach team here in Mason County through Olympic Health and Recovery Services, and they accompany law enforcement on calls. And I would say in the last couple months, we're definitely seeing an increase in our referrals from this team, from the mobile outreach team with law enforcement. We also receive referrals from the crisis team. We get community referrals, which are basically just from other community agencies who are working with our participants also and referring them to us for extra services. And then we see our self-referrals, which are just walk-ins. People hear about us from other participants, from friends, family members, and they walk into our office seeing what we do and how we can help them. We're currently seeing a fairly high volume of acuity in the participants coming in, acuity in substance use, in homelessness, and in mental health. once we get a referral, so I'll just kind of talk about that process. Once we get a referral, we schedule them with our substance use disorder professional who meets with them and does a brief assessment and intake. And the great thing about this is she can go anywhere. So if they want to come into the office for this assessment, great. If they feel uncomfortable with that, or they're very rural in the county, we can go to them. We can meet them where they're at physically and do the assessment with them. This just helps us get a better understanding of what's going on in their life, what they need some help and support with. Another part of our process for admit is our biweekly operations work group, specifically for LEAD in Mason County. And that comprises of us, OHRS, and our staff, the Mason County Public Health, Prosecutor's Office, the Sheriff's Department, and Shelton Police Department, where we go over new referrals, accept them into our program. We also share success stories with them. We have a really good working relationship with these departments, and we're currently in the process of moving towards starting to accept pretrial referrals from the prosecutor's office and the courts. So that's exciting. Once they're in our program, they're assigned a peer counselor, and that peer counselor reaches out to them, schedules appointments. And like I said before, the great thing is they can meet them where they're at, not only physically, but really just where they're at in life, where they're at in their recovery, in their journey. And the first couple times getting to know their clients, we like to sit down and do a treatment plan with them. We help them develop a treatment plan, which really focuses on the goals they have and starting to kind of break down those goals on small, achievable things that they can do. What can they do to, what can they do to help their goal? And then also, what can we do as their peer counselor to help them achieve that goal? And it can be anything from, do they need help finding a counselor, or maybe they need detox or some outpatient treatment? Do they need to, contact DSHS or Social Security for some reason? Do they need help finding employment, and how do they do that? A lot of times they've never had to do this and stay clean and sober. So do they need help with a resume or filling out a job application, or just support going to court? There's multiple different things we can help with, and I will actually have one of my coworkers talk about that a little bit more in detail. We work very closely with other community agencies, so we do a lot of referring, but we don't just hand them a phone number and say, here you go. We walk them through that process. We go to appointments with them to help them. Our program also has access to a pot of money that we can use. We're kind of flexible with that to use to help the participants kind of break through some of those barriers. So an example would be if they need some rental assistance for a little while, say they gained employment, but they need a couple months to kind of get on their feet and get some money saved up. We can help with a deposit or whatnot. We can help with cell phones, or sometimes they have a cell phone, but they don't have any income at the moment and they struggle with getting their monthly minutes. So that's a huge barrier. We can help them with that. And it not only can help them keep in contact with us, but also all their other appointments and requirements they need to keep in touch with, whether that be, the counselor or their courts, their attorney, their doctor's office, their DOC officer, whatever that might be. And then another example is we have had people who gain employment, but they need help with
maybe some work boots or some clothes to get to work or some rain gear because they have to walk to work or take the bus. So that's just some examples of what we can do. I do have Rhiannon on, and she is also one of our peers that can talk maybe a little bit more about what she does on a day-to-day basis and share a success story that she has.
Awesome. Thank you, Kisa. Good morning, everyone. My name is Rhiannon Gudula. I'm a behavioral health clinician with the LEAD program here in Mason County. Like Kisa mentioned, we do meet people where they are in their journey, whether that's their recovery journey or physically in the community. We do, we meet people at the shelter, we'll meet people in their homes, in encampments to kind of bridge that barrier. In my role, I do serve most of North Mason County, so that's Belfair, Hoodsport area. It's pretty rural out there, so getting people connected to resources is pretty important. My day-to-day world kind of consists of meeting with our participants, establishing what their goals are, making those realistic and feasible, whether that's connecting to different housing resources. Like Lisa mentioned again, we do not just give them the phone number, we make that connection. We kind of can bridge those resources as well. Like if they need to meet with the housing advocates, but they don't have a place to do that, well, they can come here. Taking to and from appointments. I do have a short success story I'd like to share. I have an individual that had been houseless for 6 years. They were staying in a motorhome that was unlivable. This was a pretty complex case. There was some medical needs as well as some substance use that was not being addressed. This individual, like I said, very complex case. They are now housed in their own apartment. They've been connected to getting their medical needs taken care of. We kind of developed this team of myself, a housing advocate, caregivers, kind of a big team together to get this person to where they are successful and prospering. So thank you. Thank you everyone for your time.
Awesome, thanks. And to support these programs, working with stakeholders, we also created some data dashboards. I know that's been a hot topic with this group. So this is an example of the data dashboard that's shared out with the stakeholders for the Mason County LEAD program that highlights some areas of interest, including kind of some referral trends and demographics, some linkages to care, how many people are being served, and how much service is happening. This is really helpful and kind of like has already been talked about, outlining that we're providing equitable services, looking at gaps in who we're serving and where people are being met, as well as kind of helping keep track of, just what types of services are of the most need. There's a lot of basic needs type services provided, and a lot of housing support. The vast majority of people that are referred to both these programs, like in a lot of regions, are struggling with not just one, but multiple concerns. So substance use is often a part of the equation, along with mental health, like was mentioned, along with extreme poverty and being unhoused. So a lot of complex needs that the case managers are supporting people through as they try to connect them to the appropriate resources. And this is a little bit out of order. This probably should have been up while Rhiannon was sharing. But here from some of the client surveys that are happening in the program, here are a few random quotes that the participants shared about their experience with the program so far out in Mason County. And I'll leave this up for a minute just because there's a lot of really cool things being said about the team. And next up, I think Mandy is going to kick off some sharing about the work that's happening on the Thurston County side of our region.
Thanks, Jason. Hi, guys. My name is Mandy Anderson, and I am the Thurston County Lead Supervisor. And I just like to share real quickly a lot of similarities between our program here in Thurston County and in Mason County. Our team, the Thurston Lead team, consists of 7 full-time peer positions. We have an additional position that is open and posted that we will be interviewing for soon. We have 2 full-time SUDPs that work with folks, creating treatment plans, performing those brief assessments like Kisa talked about. The peers meet with participants in the community and provide support with several activities aimed at supporting the individual's treatment goals. Treatment goals often consist of finding stable housing, obtaining employment, getting connected with medical providers, developing routines that support their activities of daily living, a number of different things that the peers, SUDPs, and the participants have discussed. The flexible funding is really an important aspect of the program here. It allows participants to overcome barriers that may have been preventing them from meeting their treatment goals. Some of the things that funding has helped with includes rental assistance, support purchasing household items, cleaning supplies, fuel for individuals with vehicles to make sure that they can get to different appointments. Funding can help with getting driver's licenses or ID cards, help participants take a driving exam. Perhaps they haven't had a license in the past. There's just so many different things that can be that funding can support our participants with. Referral trends right now, we get a lot of referrals from our co-responder teams. Referrals come from prosecuting attorneys for pretrial diversion. The referrals coming in, we've noticed there are a number of co-occurring disorders that participants are experiencing. Some of the barriers or challenges that participants experience are definitely unstable living conditions. It can make it difficult to find participants for peers. Participants don't always have access to a telephone. And if they do have a phone, it may only work on Wi-Fi, so that can be a barrier. Scheduling appointments can be difficult, especially if folks don't know where they're going to be from day to day. Those are some of the barriers. Jason, if you want to talk about the data, and then we'll have Nicole and Sammy share.
Yeah, definitely.
Thanks.
So very, very similar. Essentially, the same dashboard has been created for the Thurston County Lead program as well, to highlight some of the demographics and numbers of those being served and how they're being assisted. As Mandy mentioned, the SUDPs don't typically do full ASAM assessments as part of every case, but if it's a barrier to someone accessing services, they do those as needed. Lots of transportation of services and coordinating those referrals. The linkages to care category in these dashboards is always one of my favorite, because it highlights a lot of the very specific instances where if it weren't for people being referred to these programs, they very likely would not be engaging in any of these other supports that are helping stabilize their lives and reduce the harms that they're experiencing. So pretty incredible work that the team does in terms of engaging folks and getting them, helping them meet their goals and be healthier. And transition to this, if you wanted to have, I think Nicole and Sammy are with us too.
Yeah, Nicole, you want to share with us kind of what the day-to-day activities look like?
I'd be happy to. Thanks for
Thank
asking
you.
me to join in today. I appreciate it. I'm Nicole Smith. I'm a CPC and a case manager here at LEAD. I'm part of the original Thurston team, and so which means that I've been in this position for 3 years now. And so very happy and very proud to be a member of this team. When I get a referral, it means that the process that referral has been screened and management has assigned to the person which they feel is of the best fit. And at that point, as the CPC, I begin creating that relationship immediately. And so for me, I like to make contact within 24 hours of receiving that. As Kisa did a really great job of kind of indicating what we do, but all the peers have a little bit different flair, and that's what one of the joys of working for this company is that everybody has a little bit of a different twist or personality, and that becomes one of our strengths. And so I have a lot of experience dealing with people with high acute mental health issues. And somebody mentioned about having, being co-occurring high mental health and substance use. And I find that it just goes hand in hand. So we get the referral and the call if they have a number. A lot of people don't have phone numbers. A lot of people don't have addresses. So sometimes I have to go to work. Sometimes I'll get a referral and it says individuals about 5'7" in a black hoodie and white tennis shoes behind the Lacey Fred Meyer. So that means I go get in my vehicle and I will go searching for the black hoodie and the white tennis shoes. And it might mean going into an encampment. It might mean going back to the referral source and asking them to go out with me and do a warm handoff. We take these referrals really serious. In that that's somebody's son or daughter. It doesn't matter where that referral comes from, whether it's from law enforcement, whether it's a social referral network from your best friend, or somebody you've never met. They all get the same treatment. And we search for these individuals very thoroughly. And we have a criteria that we make a lot of efforts to locate these individuals. One of the things I like, or that's really special to me as far as LEAD is concerned, is that when people have failed other treatment, we define this as treatment, but this is individuals' own treatment program. It's the treatment of their definition, whatever they define, whatever they want to work on. And if that's creating a stronger family unit and perhaps that their substance use is what's getting in the way. However, they're saying, I'm not giving up my substance. We just shake our heads and say yes. And so that might mean that I may need to model recovery behavior for a long time, maybe 1 year, maybe 2 years. That's how harm reduction works. And we do the other things first. We make sure their food, shelter, and their health is orderly. And so we make sure that all of their needs are satisfied to the best of our abilities. I love the fact that we can transport clients. We can take care of things that maybe they've never taken care of before. And with that transportation being part of that process. We don't have an end date. It's not like we have 90 days to work with this individual and then they discharge. As long as they're engaging in something, they're working on something, we can continue to work with them. And that's such a value. So peer-driven harm reduction, no time limits. Yeah, I could go on and on. the program continues to give back. It gives back to the peer, it gives back to the CPC. It grows in leaps and bounds. What else do I want to share with you? I think that's all I have. I want to hear a success story from Sammy. Thanks for letting me share.
Thanks, Nicole. Sammy, you're up.
Hi, I'm Sammy. I have a similar or the same role as Nicole. We are both peer navigators, CPCs, case managers. My success story that I'm going to share, one of my peers I've been working with since January. When we started working together, they had just moved into an Oxford home, had been sober for couple months. They have 20 years of excessive substance use issues. We mostly work together just through communication and passing off of different resources. I did help with some transportation, some funds for their car, gas to get to different appointments and meetings. At this point, they are now in their own apartment. They've been sober for almost a year, and they have their first job since they were 16. They've also been able to get dentures and go to the doctor for the first time. And they are currently also volunteering at another local organization and are going to be getting their CPC certification and would also like to be a peer navigator, and they'd be great at it. So that's it.
Yeah, awesome. Thanks, Sammy. Thanks, everybody. So that is it. Like I said, I really want to just provide an opportunity for the teams to talk about their work and highlight what they're doing. And happy to answer any questions from the group.
All right, we have Rep Davis. Go ahead.
Thank you all so much for the presentation and for the great work. Two questions for both counties. The first is about capacity. Just have you reached capacity? How much more, if not, like sort of how many more referrals in the flow would it take? I get that, people discontinue services, but where are you at kind of on the capacity barometer? And the second question is, I'm just looking for a guesstimate here, but what is the percentage of time that people categorically refuse all services? In general, across RNPs, that tends to be a very low number, and it's a lot lower than the general public believes, and often law enforcement believes. There's a perception that people don't want help, but just curious if you could take a guess. So would love to hear from both counties on those two. Thank you.
Yeah, thanks, Rep Davis. So in terms of capacity, we've hit capacity really close a couple of times. Mostly that was related to staffing issues, being down at one peer case manager, or at one point we're down two, which was really rough. So in those instances, essentially what we had to look at doing was closing community referrals temporarily and only taking diversion referrals. And that worked. We did not have to turn down any diversion referrals that came through during those periods of time. And both teams are consistently pretty busy. They're often both bubbling, kind of bouncing up against the max caseloads. It's hard to if we had consistently more staff and more capacity, there could be a lot more outreach, and I think there could be a lot more referrals. It would be like a natural flow there. In terms of engagement of referrals or declining services, the vast majority of people engage in services. It might take a while to find folks sometimes. The exception would be honestly the pre-trial diversion referrals where people are in custody because people are being booked on possessions only. And in those cases, we have had less success with connecting and following through and people wanting services. I think that there would be a difference if those services were offered as an alternative to arrest. Like we've tried to set up in do, and it was kind of part of the original LEAD model. Just because of, I mean, a lot of reasons. Somebody's in custody, they don't have access to their phones necessarily. They don't necessarily know where they're going to end up. They are often in acute withdrawal. So a lot of variables that make it tough to get somebody fully on board when they're already in jail. But in general, most referrals, people engage and are appreciative of the help. There have been cases where I've heard from the peer case managers that they've had to like really assure people that this really is harm reduction. There really is no compliance. There really is no strings here. Like, we just really want to help you with whatever your needs are in the moment. Yeah.
Thanks so much. I think just a quick follow-up. I'd actually love to hear more because since we have a little bit of time, the pretrial, having the LEAD model associated as a pretrial diversion is obviously novel, right? That was the innovation in 5536. So it'd be helpful if you could talk a little bit about that in more detail, because I think the goal would be to get that to work also. And I know you mentioned it might be more effective if it were a pre-arrest diversion, but the way that is structured in statute is that the prosecutors are supposed to be able to use that to dismiss charges. So theoretically, there's still sort of some criminal legal incentive built into the model. So we'd just love to hear a little bit more granularity about that piece of the work.
Yeah, we're a little bit further behind in Mason County in terms of that shift, but it's really close. The prosecutors are on board and moving in the direction of getting an agreement in place and figuring out how that can function. I mean, I think we're, like everyone across the state, are kind of learning how to best implement that and best adjust things and best engage people. There's just a lot of aspects that have been tough in terms of people being booked specifically. It's tough to often get a referral at like 9 or 10 in the morning at the earliest, when you've got to get out there, meet with the person before noon. You've got to like jump through the hoops of getting into the jail and getting space and time with somebody. And like I said, somebody might be in withdrawal during that meeting, so it's not the best engagement opportunity. And like they're in jail. I think it's a lot easier to engage folks out in the community. But anyway, there's a lot of kind of like jumping through the kinks in that process, and they've gotten it pretty great. The outreach coordinators can get out to any of our local jails really quickly to meet with people and talk about the program and offer them services and do their best to gather information to help with follow-up when somebody is released. And I think we'll continue to kind of figure out the best ways of connecting with people and engaging them. And I think that it's always going to be most ideal if we can get field-based referrals from law enforcement in the moment as an alternative to booking someone into a jail.
Thank you.
Yeah.
All right. Excuse me, Malika.
Yes. So to your point, LEAD is a pre-booking diversion, and it is hard to find folks when you are having to go search for somebody in a black shirt and white tennis shoes. Like, I've done that. I know what you're saying. I'm wondering what is the holdup with like arrest diversions and the 24-hour response to a referral. With the LEAD model, if it's an arrest diversion, 30 minutes is the golden, hour, half an hour. So just wondering, what is the barrier?
Yeah, those ones are community referrals. Diversion referrals are always more in the moment. Anytime we can get those there. So there's been some kind of like, I don't know, how can I describe this? So there was a Blake decision happened early on in starting up both these LEAD programs. And at that point, law enforcement just kind of stepped back from that at all. We've gotten a couple community referral or social contact referrals, but the vast majority of those at this point have been, like we already talked about earlier, was from the co-responder programs. So co-responders are making a ton of alternative response that then go over to LEAD. Law enforcement directly still have not provided that many referrals to these programs. We're hoping with some expansion funding, we're going to add a new outreach position that's like sole focus is going to be working on the law enforcement referrals and relationships to create more. But it's already been set up to where we've gone out to all the local law enforcement agencies. We've talked about what response can look like. We can prioritize response to them. I mean, depending upon where you're at in Thurston County, it might take 20 to 30 minutes. Mason, it's a bit longer, depending upon where somebody's at. But either way, there can be in the moment response for those kind of referrals. We just haven't seen a lot of buy-in or many follow through at this point outside of referring to the co-responders to handle that. Both the sheriff's office definitely rely a ton on their co-responder programs and kind of see them as the avenue for programs like LEAD and other resources.
Thanks for the answer. And I have one more question. So I was noticing on your demographic data that after white, not reported was the second highest demographic, like racial demographic. And, you know, LEAD was designed to help start addressing racial disparities. So I was wondering if you all had been looking at the data related to demographics and seeing who disproportionately is it being impacted, and then what, and also is the not reported that not reported by your staff or not reported by the individual, or can you tease that out?
Yeah, it'll be not reported by the individual, and that's been something that we've been talking about and working on for a while. It's gotten a lot better. Let me see if I can go back. So we're down around 10-ish% not reported at this point. And most of that is, well, there's a lot of reasons why that ends up being there, but we worked a lot around different points of time. We can collect that and what's the most kind of client-centered way to approach that and collect that. So that has gotten a lot better through the years, and there's still room for improvement. And the other piece of your question, yes, we've worked with, at least on the Thurston County side, we've worked with the county to look at some of the demographics that they have access to in terms of what's the populations that are most impacted by the criminal legal system, to try to like at least get like a rough proxy for, is there semi-equal representation? I don't know if that's like the best way, but at least gives us a general idea in terms of who's being impacted by the criminal legal system and what are we seeing represented in programs like this.
All right, thank you. Any more questions?
Lake, there's some questions in the chat from Jamie. I don't know if maybe Jamie just wants to go off mute and kind of elaborate at all, but they're also, I mean, there's enough detail there where maybe if you can read them out loud for Jason and his team.
Yeah, we can do that. So the first question is LEAD providing transportation again? Several of my participants said they cannot be transported anymore. I've also had numerous people mention that there is not funding available for additional client expenses anymore. Any comments about that?
Keith might be able to get into the details on that a little bit more. I know in general, transportation is available in both counties, and the agency has fleet vehicles to support that, and client supports are definitely available. I've heard of situations where there have been safety concerns, where issues arose where it was clear indication that it wasn't safe to transport someone, or it wasn't safe to transport someone alone. I don't have no idea if that is potentially a factor in any of those cases. The other piece is you typically, I think, Kisa, if you're still on, you can correct me if I'm wrong, but typically like transportation or support funds aren't really accessed until somebody's engaging with the program. So it's not like a situation where somebody can just walk into the office and say, hey, can I get a ride somewhere? Or hey, can I get a phone necessarily? I think there is flexible funds that can support kind of engagement and initial outreach. I don't know if that is at all relevant to the question about the details. And of course, I don't want to talk about specific cases either.
Jason, could I add something?
Sure.
Yeah. I sometimes clients are wanting us to just take them places and to their friend's house and things like that. So I have to be really clear with them that transportation have to be able to link to something pertinent on their treatment plan. So it's really specific types of transportation. So, and there, I have had a situation where one of my clients, the intended visit didn't go the way it was expected. And so it was agreed that that activity wasn't going to happen again into the future just because it created other issues. And so we weren't going to transport to that environment again. And so for us, it was a case by case basis. So I just wanted to add that.
Thank you. So the second part of that is, go ahead.
Oh, sorry. No, this is Kisa. I was just going to say, no, you covered it, Jason. We are actively giving clients, we're transporting them on a regular basis. I mean, we've seen, we do have a limited amount of fleet vehicles and multiple peers, so we get busy. And we've had clients call and demand, at a drop of a hat that we do something, but we have to have those conversations where we need a little bit of time to know when your doctor's appointment is or when your court date is, so we can schedule a fleet vehicle out so we are able to pick them up and help transport.
Thank you. The second part of this is I'm also curious if league guidelines have changed as the former guidelines were. Chronic contact with law enforcement as a result of mental health, substance use, or extreme poverty, rather than chronic contact being possible criteria. I know if we can refer more community individuals in that just have SUD or mental health. Hopefully that made sense.
I think so. I know the county and the PCG out there is working on updating some of the protocol documents, so that could impact us a little bit. But the priority population is still going to be those with frequent contact with law enforcement, or minimally high risk for frequent contact. So they're still definitely looking for that nexus in terms of who fits for these programs.
Okay. And let's see the last one. How many diversion referrals are we getting in Mason County?
So none. We've had social contact referrals. We've had referrals from law enforcement and the co-responders to the program where potentially definitely could have been a charge, but the co-responders were sent instead and they referred to lead, or law enforcement opted to refer to lead instead of pursuing that, but it wasn't officially a diversion. The PCG is working on the policy coordinating group, is working on, along with updating those protocols, an MOA currently with the prosecutor's office that they're on board with that will hopefully result in more of the diversion to the pre-filing, pre-trial phase. And like I mentioned earlier, also continuing to try to engage law enforcement to make some field-based referrals. We've seen more, from what I can tell you anyway, we've seen more charges in Thurston County related to possession. We haven't seen as many in Mason County. But that's what we've seen so far.
And Jason, this is Tony, and thanks. I think your kind of background and explanation as to like why that may be with when the Blake decision came down, and then law enforcement basically being directed to refer individuals a minimum of 2 times as a result of 5476, and maybe kind of unexpected outcomes from that, I think makes a lot of sense. And also, it also sounds like the ORs and the partners are continuing to work with law enforcement to try to create those pre-arrest, pre-booking pathways, which really appreciate. There, not necessarily a question, but some really good comments. And thanks, Jamie, for your questions. I haven't met you, so nice to meet you. Sounds like you're involved in the Mason County area. Lisa had some comments in the chat as well. And Lisa, I don't know if you just want to go off mute and kind of, share. I think it's really helpful and important feedback.
Sure. Thank you, Tony. I originally commented about pretrial and pre-filing diversion, and I'll just summarize that. But real quick, wanted to comment on Blake's question. So the nuance, and I really appreciate, Jason, your point about continued focus on those who are likely to be intercepted by law enforcement. That is the focus. Sorry, that is the focus of LEAD. But it's not a super mechanical analysis of whether someone is being contacted, because as we know, that is greatly affected by workforce issues and capacity issues for law enforcement. The issue is whether they could be, because there is chronic law violation and essentially an expectation of public expectation of enforcement. So mechanically, having us during screening looking at whether there has been recent contact is less important than whether there's evidence that somebody is chronically and very publicly violating the law. And if we don't respond, then there will be another response. And so that nuance is really key to maximizing the value of this intercept. But going back to the pretrial and pre-filing discussion, first, I really want to commend Thurston Mason. You all have been among the most active around the state. You're not behind. You've been among the most active folks in the state in figuring this out. The logic of making pre-trial and pre-filing diversion to these services possible arose because diversion is no longer mandated, pre-booking diversion is no longer mandated yet around the state. And so some people are going to end up driven further into the court system because it's a law enforcement option. Yet this is where the state has funded statewide low barrier resources that work for a lot of people. So making them accessible, even if people are jailed and or filed on, is that there's a strong logic to that. However, it's also true that once people are on a trial diversion, are in a pre-trial diversion posture, there's a strong culture in court. I say this as a longtime misdemeanor defense lawyer. There's a strong culture in court of judges deciding whether or not someone is doing what they should, setting conditions, and not accepting the guidance of experts, recovery experts, essentially. And so, and there's also the strong risk of RNP or lead case managers becoming witnesses against their own clients in a pretrial diversion revocation proceeding. So this posture just introduces additional challenges in planning. And so the Lead Support Bureau, HCA, the AOC, the Administrative Office of the Courts, increasingly prosecutors and defense have been strategizing about how to set this up for success and not have everybody get into a posture where they're like, oh my gosh, this is really turning
lead or RNP case managers into effectively pre-trial probation. And that is not the logic, and it will compromise those teams' ability to work with clients who are then going to not tell their case manager what's really going on in their life, because then the case manager gets turned into a witness against them. So we all think that there's a way of doing this that's going to work. We're presenting at a number of conferences coming up about it. So just really want to commend, I think Mason and Thurston are really actually at the forefront of thinking this through, along with a few other jurisdictions.
That's awesome. Thanks, Lisa. I got one quick update to add really quick. We do have 2 arrest diversions out of Mason that we've gotten recently, actually. So I will know more about those cases after the next OWG on next Thursday. So that's exciting.
Go ahead, Tony. Thank you, Jason. Go ahead, Tony.
Yep. Thanks, Lisa. Thanks, Jason. And I realize that we're bleeding into the public comment section of the agenda, so I apologize for that. But it really worked out, because I think this is a really helpful conversation. Jason, your data dashboards were awesome. Where are those built in-house with like your electronic case management system, or can you, I mean, we talk about data a lot, and it seems like Thurston and Mason have, you know, like Malika pointed out some of like the unknowns in there, and it sounds like, you know, there's efforts around that. But yeah, just curious if you can share more about how you develop those.
Yeah, I mean, it was largely based around some of the modifications to the case management record that came out of the RMP guidelines. So we added all these cool checkboxes to accommodate the reporting needs of the workbook that we're sending in. But since we incorporated into the health record, it can kind of be automated into these reports. And we're able to kind of pull out different pieces of the information to provide at least general snapshots. So, you know, one easy example is within the lead case management notes, there's different drop downs and different selections for if there were any additional services provided, whether that was going to a local CSO or going to the SSP, or, you know, taking somebody to outpatient treatment. So there can be really specific kind of like those points captured that then can be later on shared as, this is how many times we transported somebody to treatment. This is how many times we filled out a housing intake for somebody. And like I said, it was partially out of adjusting the data to accommodate the Recovery Navigator reporting needs, and then talking through PCGs in each county about what would be most helpful for people to see, to give them a snapshot of the work that's happening.
Thank you.
Okay, any last questions for our presenting group? Again, thank you so much for your presentation today.
Yeah,
Appreciate you all being here. Thank you. All right, so we have another public comment period here for 5 minutes. If any member of the public has any comment they would like to make after hearing what we heard today, please go ahead and raise your hand, and we'll take that comment. Again, if you would like to make a public comment.
Like, you know, while kind of anyone thinks about a question that they may have or a comment, just kind of throwing it out there, and it's kind of, we're kind of melding walk-on items with public comment. But I'm just wondering, like, with our representative from the Association of Prosecuting Attorneys, Chad Enright, as well as John Hayden, who represents the Association of Criminal Defense Lawyers, you know, would it make sense for a future meeting to talk more about like this new pre-trial diversion pathway that, you know, Lisa and our Recovery Navigator programs and sounds like Thurston and Mason are kind of working on, like, would there be benefit? I guess I'm opening this up to the committee just to see if this is something that they feel would be helpful to have kind of like a dedicated time on a future agenda to kind of talk about that a little bit more. Since we do have our, those associations represented by Chad and John. Be interesting to hear what the association's kind of take is on that new requirement, even though it's not really new. It's been around since May of last year, but.
Well, I know that, and this is Chad from Washington Association of Prosecuting Attorneys. This is actually something that we are going to talk about Tuesday and Wednesday this week amongst prosecutors. I thank Lisa for contacting me last week about some different things that we can do. So right now, I don't know, but I might have some more information that I can give you next meeting on a path forward.
Awesome. Thanks, Chad.
And this is John Hayden. I think that's a great idea. My suspicion, and I don't have any empirical information, my suspicion is we have widely varying approaches around the state, and I think that's something that would merit some discussion.
All right, thanks so much.
Okay, didn't look like we had any public comments, no walk-on items. So Kelly, back to you.
Yep, thank you, Blake. Hey, Cody, real quick, you want to show the word cloud real quick, and then I'll share my agenda at the end. Oh, actually, you know something, Cody? I'll share my agenda first because it'll go quicker. So I'll just share.
Is Cody still there?
Yeah, I think he is.
Yeah,
Cody,
I'm here.
Cody, thanks so much for sticking around for an hour and a half. Really
No worries.
All right. This is the October agenda as it sits right now. For right now, I just have Michelle Martinez doing it. There could be changes in the October agenda. I'll email them out. We're having a meeting after this. Myself, Tony, and Sarah will all be out during that day. Me and Tony are going to a CAW conference, and Sarah already had planned being out of the office. So, yeah, so we'll email you if there's any changes in the agenda or timelines. For right now, we have public comments set for 10 minutes, and then walk-on request items, and then overdose data from 2023, time given to Tim Cadella from the DOH, and then RMP report from Brianna Peterson. And then we also have RMP highlights. We plan to have 2 to 3 RMP participants with living experience sharing. Names are to be determined, and then public comment, and then walk-on items, and then next steps and review action items. And that's how the agenda sits right now.
So Kelly, real quick clarification, is there room for additional items as of right now? And again, committee members, like, we're presenting this now for feedback. If there's anything we want to change, add, remove, postpone, but it seems like it's kind of jam-packed unless
Yeah, because I added Tim at the last second because it was a request from 2 months ago for that. And so I've added it on this agenda.
I guess what I was thinking is, like, we talked about it last month, but maybe like an update on our state's unlawful possession of controlled substance filing data. That it may, it seems like we're going to have a really data-heavy meeting, and they all kind of intersect to some extent, whether it's overdose data or unlawful possession of controlled substance, statewide filing data, or the Recovery Navigator Program dashboard. And so just kind of putting it out there to the committee to see, like, if we're able to coordinate that and have a partner from research and data analysis come and share kind of what we're seeing across the state, like, since those, since the charges became gross misdemeanors last year, would that be something, if we're able to fit it in, would be would be helpful? Just bringing it back because I brought it up last month and didn't want it to kind of. And maybe that's something to think about, and then, we can send a follow-up email out as well. And then, you know, as kind of considering that, also the October meeting, if I'm still going to be the interim chair, and you know, hopefully by then we might have like an actual, you know, be able to share an official update about who will be chairing this going forward. But I would like to be there. And so I don't know if others in the committee are planning on going to the co-occurring treatment conference in Yakima, which is the conflict that Kelly referenced. But yeah, and so just kind of throwing out there, like maybe we reschedule October, just to ensure that, you know, Kelly's there and I'm there, especially since I just proposed adding an agenda item now. I'd have to kind of help coordinate. So things to think about, and we can follow up by email, maybe with like a poll, you know, just in case, like if we're expecting a lot of committee members that might be out at the co-occurring conference or out for something else as well.
I can do that, yeah, for sure.
Thank you.
I'm gonna go ahead and stop sharing now and pass it back over to you, Cody, so you can share the word cloud. 52 responses. Ooh. And then we can get this in a PDF, right, Cody?
Cody, you're muted if you're.
Oh, yes, sorry. Yes, I can get it in a PDF and send it your way.
Go ahead and do that, and I'll send it out to all the I'll send it to all of SURSAC, and you guys will have this. I just want to notice some of the words: healing trauma, second chances, opportunity, peace, action, dreams, resilience, love, hope, fellowship, healthy, learning, health, power, grace, choice, possibility and renewal, presence, effort, life change, liberation. These are all just great words that everybody's focused on. I'm really appreciative of the whole committee sharing this with us today.
Yeah, and you know, having freedom, peace, and hope kind of being like the most recurring words, terminology used, I think says a lot, you know, in terms of like freedom from fear of punishment for being somebody who's treating your substance use disorder through self-medication, freedom from feeling like every 2 hours you have to obtain a substance and use it, or otherwise you get deathly ill. You know, I think freedom, you know, says a lot, as well as peace and hope. It's really, really reassuring to see hope up there, because I think a lot of times when you look at the data and you're, you know, we're talking about these really complex systems that we're trying to change and improve to better serve individuals. Knowing that there's hope there is just so critical. So just really appreciate everyone that participated. Is that it?
That is it. Back to you, Blake.
All right, folks. Thank you for your attendance today and your participation. We will see you next month. Thanks so much. Have a good one.
All right, take care, everyone.
Have a good one.